If you want easy points on your shelf exam, you need to know the ins and outs of alcohol withdrawal. It's potentially lethal and considered a medical emergency. The mechanism of action is opposite of that of intoxication. So since chronic alcohol use has a depressant effect on the CNS, stopping the use causes hyperactivity and glutamate excitotoxicity. Alcohol withdrawal delirium is the one delirium that is treated with benzodiazepines, and that's important to know for test questions. Both alcohol and benzos act on the GABA receptors, which is why benzos are used to treat alcohol withdrawal. Let's talk about symptoms. Since withdrawal symptoms are the opposite of intoxication symptoms, you have to think, what's the opposite of a drunk person? So you're going to see someone that's tremulous, having a lot of anxiety, insomnia, irritability, psychomotor agitation, and hallucinations. They're also going to show hypertension, tachycardia, sweating, and commonly nausea and vomiting. Test makers love to test on the high-yield timeline of alcohol withdrawal, so you want to pay close attention to this. First of all, there's the onset of earliest symptoms, or mild withdrawal, that occurs between the 6 and 24-hour mark after the patient's last drink. For seizures, you typically worry the most between the 12 and 48-hour mark after the last drink. That's the same timeline as alcoholic hallucinosis, which also occurs within 12 to 48 hours after the last drink. Delirium tremens is probably the most tested topic in alcohol withdrawal, and that typically occurs between the 48 and 96-hour mark after the last drink. Because delirium tremens is such a high-yield topic, we're going to talk about that in more detail. It is the most serious form of alcohol withdrawal, and key manifestations are delirium, agitation, autonomic instability, hallucinations, and gross tremor. Now, it is important to note that DTs involve the delirium and autonomic instability because that is what distinguishes them from alcoholic hallucinosis, because test makers like to test on your knowledge of the difference between the two. All right, management and treatment of alcohol withdrawal. As we discussed earlier, first-line treatment is benzodiazepines. In the real world, there's other things that we use for alcohol withdrawal, but on the test questions, the answer will be benzos. You also want to think about nutritional repletion because chronic alcohol use can cause a B1 deficiency, which is highly tested on exams. This is why you need to give someone with alcohol thiamine as well, and make sure that you understand that you need to get thiamine before administering glucose. The thiamine is necessary to prevent Wernicke's encephalopathy, which is also a highly tested question. For monitoring, withdrawal signs and symptoms should be monitored using the CIWA. And you need to know that for clinicals because we frequently use CIWAs on the wards. Now let's go through some practice shelf questions. A 30-year-old male, 36 hours into alcohol abstinence, reports seeing bugs crawling around the room. He remains fully oriented and his vital signs are stable. This clinical picture is characteristic of what? Alcoholic hallucinosis, delirium tremens, moderate alcohol withdrawal, or Wernicke's encephalopathy? The answer is alcoholic hallucinosis. The key distinguisher between this and delirium tremens is that his vital signs are stable and that he is fully oriented, whereas in DTs, he would be disoriented and have autonomic instability. Next, we have a 65-year-old male with a history of alcohol use disorder who was hospitalized for a hip fracture. He develops confusion, visual hallucinations, and a fever with marked tachycardia. What is the expected time frame for the onset of DTs following alcohol cessation? A, 6 to 24 hours, B, 12 to 48 hours, C, 48 to 96 hours, or D, 5 to 7 days? The answer is C, 48 to 96 hours, which is the scariest time for providers because that's when DTs can occur. Now we have a patient that is admitted for alcohol withdrawal, and requires aggressive hydration and nutritional replacement, including IV fluids containing glucose. To prevent Wernicke's encephalopathy, what is the most critical intervention that must be performed first? A. Administering a multivitamin. B. Drawing a complete blood count and chemistry panel. C. Giving thiamine. Or D. Correcting fluids with dextrose solution. The answer is C. Giving thiamine. It is important to know, as I said before, that giving thiamine should be done before administering glucose. It is a necessary cofactor for glucose metabolism needed to treat Wernicke's encephalopathy. It's also important to note that thiamine is way more effective when it is IV or even IM. Oral thiamine is not that useful. That's more clinical knowledge than test knowledge. Finally, we have a patient that develops confusion, agitation, perceptual disturbances 2 days after being admitted to the hospital after a car crash. What is the first line of treatment? A. Haldol. B. IV fluids. C. Lorazepam. Or D. Thiamine. The answer is C. Lorazepam. Again, benzos are first-line treatment for alcohol withdrawal. You're going to see in most of these test questions, the person has been admitted to the hospital where they can't drink alcohol, and then they start showing signs of alcohol withdrawal. So if you see someone that has a delirium after they've been admitted to the hospital for a couple of days, alcohol withdrawal should be on the top of your differential. All right, that is it for today for alcohol withdrawal. I hope this gets you some easy points on your exam. Good luck.